Good afternoon, everyone. Thank you for joining us today. We're going to be talking about revenue cycle, and we are joined by one of the newer Wintergreen team members. And Carrie, I'll let you introduce yourself and give a little bit of your background. And we're looking forward to your presentation today. I know we're light on the live attendance, but if you're watching this recording, if you have any questions or concerns or anything, please let us know. And with that said, Carrie, I will turn it over to you.
Great. Thank you, Laura. So, a little bit about myself. My name is Carrie Bova. I have over 15 years' experience in revenue cycle management and rural healthcare. Rural healthcare specifically is my passion. I feel the social and economic benefits of providing healthcare services in rural communities has m- multiple and lasting effects. Um, I specialize in critical access, RHC, and behavioral health services in rural communities. Um, but today's presentation, we're going to focus on how to review and provide some optimization suggestions to ensure that you are focused on identifying, managing, and generating patient service revenue effectively in your organization. We got a bit of a delay here. Sorry about that. Organizations today, and I know there are many people, but they are facing a whole new healthcare landscape post COVID. And traditional methods that may have worked in the past to improve revenue cycle performance, while still they're valuable, they've become antiquated a bit. Um, Recognition that rural healthcare facilities have to react quickly to survive is it's increasingly evident every day. And I think because of that, we have to establish some new strategies to achieve optimal performance, and they're critical to the foundation of short and long term success. So, quickly, the agenda: understanding revenue cycle, analyzing your opportunities, looking for some of that shared responsibility, talking about integrity, revenue integrity, and reimbursement strategies, and then basically closing out with some denial management and data analytics suggestions. So, understanding the revenue cycle. The revenue cycle has multiple and specific to rural healthcare, even. There are several functions housed in several different ways, and each individual organization can be different. The most important thing is to evaluate and improve the functions. And you can do that a lot by ensuring some fair distribution of work with clearly defined roles, task documentation, automation, and improvement. One of the things that I find as I travel is there's not a lot of task identification, really drawing out the roadmap to success and who's performing what, and how maybe in some cases those things could be expanded upon. And make sure that no matter how the tasks are divided, core task elements identified here um, are both incorporated and monitored. Monitoring is very important for revenue cycle success. So, analyzing and identifying the opportunities. What's the current state? What are your strengths? What are your weaknesses? What are the opportunities that exist either due to regulatory changes or within your own organization? And what are the threats associated within your current revenue cycle operation? So really start looking at like pre-claim functions, establishing workflow priorities. Are your contracts reviewed frequently, up to date, and do they effectively cover the cost of services that you're providing on the reimbursement side? It's really the first step is identifying where you can begin your optimization. And there are many presentations that will say, oh, well, you should always do this, this, and this. This is really more about recognizing that every individual organization is a little bit different. So there's really not a cookie cutter approach. And we all wear multiple hats. So, some key areas of focus as you're evaluating your tasks assignment and the different revenue cycle functions is really take a look at contracting. Immediately identify if there are payers who offer incentive contracts and request an amendment. if you're performing preventative services and things of that nature, look how to meet quality measures and get additional service revenue just by the work you're already performing. Looking for services in which the adjustment is more than what's paid. Are your charges too high or is your contract costing you money? Most payers are required to renegotiate terms at the request of a hospital or organization if there's a negative financial impact to serving that particular payer's membership. So don't always think that you have to stay within those contract 3-year terms and you can never request amendment prior to the contract term day. That is not accurate if you're financially having financial difficulty based on reimbursement. And I think it's really important because even inflationary expenses have to be identified and considered in our contract management. And just cost of living increases and cost of obtaining providers and labor. It's something that you really need to get an evaluation done and then really continue to evaluate as you move forward. Um, so the other really quick focus is when you're doing your contract review, really check for those EDI transactions. Anything coming or leaving your facility via paper right now should not be. EDI transactions are the new normal and they're expanding. Pretty soon we will be attaching records to Medicare claims to support medical necessity. There's lots of talk of changes. So make sure you really have everything paper in your analysis, starting to identify how you get that electronic. And then if you have any claim submissions or remittances that are coming back via check or paper remittance is coming in the mail, all of that, that's a really significant cash flow impact. It can really improve like claim to payment ratios can be anywhere from 9 to 12 days as opposed to 35 to 45. So it's really a benefit. Really take a look at the roles and responsibilities in your organization and identify those tasks that could be automated or expanded to avoid additional labor lift or to free up someone else's time. Often, two roles do the very same thing, or they have very similar processes, but two people are doing very similar processes that could be combined to get the same result. And then really look for those solutions of automation to make the most effective use of subject matter expertise. Are you creating workflows? Are you creating um, work queues or lists that will help your organization really have timely turnaround of cash and responsibilities for pre-registration, etc. The next thing I really want to talk about is schedule resource utilization. Are you making the most of the time that you have? In a practice, provider preferences for appointment times can drive lower than standard volumes, and they do have an impact on cash. But taking it a step further and really finding a way to make optimal use of scheduled hours of your labor force and your staff, it's a really important growth initiative and strategy. And one critical access hospital that I know used respiratory therapists to help meet chronic care management for COPD time by having soap notes and reaching out to the patients that were enrolled in chronic care management. So really, when your nurse is overtaxed, is there someone else that can help you meet and still create that revenue generating service? And then really expand telehealth opportunities to mitigate low no show or lost revenue, or maybe even underutilized hours on your schedule. Start looking for telehealth appointments or virtual check-ins with patients that frequently no-show. It really, really can help make a nil claim or a complete loss turn into at least a few dollars. Moving on to expense reduction or reassignment. Often, if you're looking at softwares and duplication of roles, tasks, etc., you can see that some softwares are doing the same thing but different. And it can be identified through the analysis so you can reinvest maybe that expense saving into a care management program, into an eligibility software. There's just different different ways to take a look at that during your analysis. So contract analysis, I really want to just point out there are payer contracts, they have fee schedules and certain reimbursement requirements. Just really paying attention to monitoring what's in those contracts and having the right people at the table to talk with you about that. So, for example, if you have a contract that indicates you have a $300 ED all inclusive rate, that's probably not the most beneficial and it is probably financially impacting your organization. The other thing that I've identified through some different assessments is there's a failure to identify the principles that are afforded to critical access hospitals or rural facilities based on the designation. And don't be afraid to challenge the payers. Um, on those. So what that means is the 1 to 3 day payment provisions. So your outpatient ER and your inpatient, some of the commercial payers say that's one encounter. Critical access hospitals not subject to 1 to 3 day payment windows. So really taking a look at how do you build those kind of provisionary regulatory reliefs into your third party payer contracts as well. Look for those contracts that don't have that have very specific language and don't have generic language surrounding your Medicare rates, like percent of charge ratios, etc. They shouldn't be spelled out. They should be per the current year fiscal intermediary rate letter. Um, Really, failure to monitor and maintain provider services and appropriate demographic information with the payers that tends to stick out a bit. A lot of contracts don't appropriately identify pharmacy and supply reimbursement, and they have a failure to recognize provider based departments and technical components. So, really keep that in mind throughout your analysis. So then it just, I really say that everyone should try their best to optimize revenue cycle tasks and functions. I mean, here's just a chart of what some of these look like, but the administrative functions of contract negotiation, your CDM fee pricing, your transactional enrollment, and your provider enrollment and credentialing. They have a lot of risk all prior to any patient encounter. So, really taking a look at that. It's very difficult for some rural providers to provide pre-registration, but looking at your workflows to determine if there is a way to do so, it really, really helps with financial clearance and meeting the No Surprises Act requirements for good faith estimates. So these are just the different areas, really pre-claim, front end, the transactional components with coding and claims, and then really some denial management and data analytics. So keeping all of that in mind and making sure that the core functions that are required for each of those roles should be identified. We talk a lot about identifying duplicity and redundancy in these workflow tasks. So, really looking at technology for clinical documentation templates, workflow automation, and electronic record incentives. There's been a lot of duplicity in what everyone does. Multiple EMRs, they go to multiple different places. The duplicity can have a significant expense organizationally. So, one thing is really identifying some key stakeholders, such as department heads, information technology, and even the software vendors, and really review the softwares, what they do, if they're optimally performing or if there was partially failed implementation. It can really hurt your bottom line. So taking a look at that and sometimes identifying that duplicity can free up enough revenue in a budget to invest in a care management program or some additional services. So keeping that in mind. Revenue cycle shared responsibilities. Again, as we talk about tasks, roles, and what's important, we really need to talk about clinical and financial collaboration. Successful leaders, I say this year more than ever, are looking for opportunities for collaboration internally and externally to learn and grow from some of these external stakeholders. so it has an increasing impact on revenue cycle functions. Communication between finance and providers in your organization, maybe a CDI. It's really critical to both revenue generation, but also revenue retention. You're identifying any risks that are out there. And you're really helping clinicians become invested in your organization. We want to educate them on and to make sure they have accurate understandings of the costs, of the time, and the resource use and communication methods to make sure that claims or patients are taken care of both timely and effectively. Um, so, just a few things: collaboration and routine meetings with clinicians can help improve service revenue. I recommend coding and billing staff in the office or a practice manager identifies, E&M level opportunities, smoking cessation, things of that nature, and really communicates back on the audit of the documentation. Um, Often providers simply need to know if they documented time, you'd get one more code, and they're very gracious of that. It can mean recognizing procedures through better documentation and add-ons by having a better understanding of their billing. And then equally, revenue cycle staff can learn more of what providers are actually doing, and really take a look at the charge capture and if there's opportunity for add-on or additional procedures in the documentation. So steps to improved resource utilization, really getting an overview of the current state. I recommend, like in your clinics, establishing a scheduling template that is based upon best practice, not provider preference for appointment times. Really allocating people and defining the tasks and resources to a more granular level, but also an overlapping one. And it really can help with balancing those workloads and having a healthier collaboration model with your teams. Um, Implement solutions in, a this is an example, but in a practice schedule for acute care and no shows. Maybe no shows immediately go to a provider who's free, or during a provider free time for a virtual visit. Maybe there's opportunities there. Also creating a wait list, block hours, and a telehealth strategy to really fill in those vacant slots. And then I'm really focused on that care management. We see behavioral health transition is new. I'm not sure if anyone is doing that, but we're really seeing that care management of our patients and really having a holistic approach to providing care is seems to be that where the trend is headed. And then just really establishing a patient friendly workflow. Make sure book appointments with a full internal staff flow. So you're booking an appointment and you're having them contacted, and maybe you're collecting their copay or you're providing their financial counseling, really establishing a really patient centered workflow to make them feel happy when they leave and wanting to come back to improve retention of our patient base. And then basically, I say establish benchmarks, not just for your staff and your revenue cycle, but mostly for providers to ensure that they have financially viable operations like RVU averages, minimum volumes, really asking what are they going to do and what set the expectation. Revenue integrity and reimbursement strategy. I think that revenue integrity has similar but different meanings in the industry, but to me, it is ensuring that all appropriate charges for a service, all the supplies, everything that it took to serve that patient is billed, and then the billed service revenue is received and it's been billed in a compliant manner, really mitigating and eliminating any risk of future audit, recovery, etc. So really taking a look at charge reconciliation at the department level, making sure that everything is captured, performing routine billing and coding audits, and then really start paying attention to service line contribution and their accountability analysis, like who has the most late charges? Are they always late? Are they always missing? And really identifying the importance of timely and efficient documentation and billing. Um, so moving right from that, I would recommend establishing, if you don't have one, a charge reconciliation process. So everything that left the department or was provided in the department that day is billed for. Charge reconciliation is just comparing what was captured to what service was provided and really start taking a look at if anything, again, is missing that revenue integrity piece. So really take a standard of acceptable charge lag. Best practice for documentation and charges, 48 hours. Should not be longer than that. But we all know the reality is it's more like 5 to 7 days before we see all of those things ready. And that's okay. Starting at a baseline and really getting down to an acceptable, everything should be closed, specific to cause that I am aware of within 5 days. Um, and then really establish that accountability at a department level. Ensure departments reconcile frequently and you're tracking missing charges. You don't, every missed opportunity leaves money on the table. So it's very important. Maintain and review your and maintain an up-to-date charge master. Make sure you're not billing for expired codes. You routinely are looking at the updates from CMS, and your pricing is not below any Medicare fee schedule. Many contracts still have lesser than logic in them. And you want to make sure that none of your fees are below fee schedule allowances. And then really educating departments and key stakeholders on what the missed opportunities were. Going back to that provider communication can be very helpful to generate additional service revenue with your existing patient base. Reimbursement strategies. So evaluate claims for payment variance. Are you getting paid what you should be? Are you getting your AIR? Are you getting your correct percentage to charge ratio? Really immediately evaluating those claims for accurate charge capture, coding, and billing. Um, and demographic capture. A lot of eligibility related issues cause claims to not be reworked and turned around timely. So that's an immediate strategy you can do for past claims. Present claims, present opportunities. Invest in the front end processes and management to grow existing revenues from your patient base. So one of my hot button topics is preventative service eligibility. The Health and Human Services Department just recently um, has an initiative that says Healthy People 2030. They're really focusing on holistically improving the health of patients. And because of all the efforts that have not been successful or haven't made marked improvement yet, I think we're going to see the industry trending on some value based care, either incentive or penalty at some point. Um, and then future state, by implementing and monitoring workflows focused on preventative care, care management, future revenues will be received in the form of incentive, increased payment, increased charge capture, and then basically it will release from payment penalty or risk if we're monitoring all of that very well. So your reimbursement strategy for the past, here's just some quick tips. I'm not going to read through all of them, but I really think they're important to do. Really looking at claims for where and identifying trending analysis can really help you work projects and get cash acceleration by resolving a bunch of claims at once. Reimbursement strategy for the present, again, front end processes that'll identify quality gaps and preventative services, really focusing on point of service collections, and it'll identify additional opportunities through revenue capture and providing quality care. And then the future. Again, pursue that preventative service while making strategic advances toward educating staff and providers on quality measures, grow as you know approach. So your front end staff can run preventative service eligibility on your Medicare patients. I implore everyone to check one today and just have them go in and check the tab that says preventative services on Medicare. The average preventative service revenue that can be between the clinic and the parent entity can be anywhere from $500 to $2,000 per patient, per Medicare member, just for services they're eligible for and have no copay for. So many things, such as a AAA screening, an annual depression screening, low dose CT. Many of these things are not being completed, but have significant benefits in prevention of disease or early detection. Educating, and communicating that with your patients and with your providers, it can improve out of pocket cost, and it helps really not pack up your ER at times. And then really taking a look at the contract, doing that contract analysis and looking for where you're really taking a hit in your contracts on what service lines you need amendments for, and creating addendums so you get more money and more reimbursement. So many folks will increase charges as opposed to negotiate contract amendments. When you increase charges, you're just passing that money on to your patients, which is not a marketable strategy in a lot of cases. Moving right on to denials management. Denials are going to be so important, and so many organizations have a huge AR over 90. They, coming back from COVID and staffing challenges, are really not able to manage the day to day operations. Can't get to AR is a thing that is ringing across the industry. We're fighting for financial sustainability, just due to increased operational costs and wages, inflation, all of those play a role. So we really, really have no choice but to establish a denials management protocol where every dollar counts, gets looked at and reworked. Um, MGMA poll again from 2021. Payer increases and denials were up 17% across the industry. And then, of all of the denied claims, only 40% were resubmitted. Um, that's a startling number. Um, so, really establishing a team to identify a denial management strategy. I mean, identify the resources, leverage expertise and input. I mean, if you're getting a lot of medical necessity denials, then, you know, find a provider who can do a medical necessity dictation that will support higher cost testing. Organize your processes. I always stress this. Create an honest environment for the CFOs in your administration. So many people do not report true denials. They report denials that they determine they don't go specific to ANSI remittance codes and remit adjustment codes that truly identify what's being denied. Really taking a look at that, because it contractual versus denial adjustment really is something that we have to pay close attention to in the industry, and we have to not, in order to manage our contracts, we can't write everything off to a contractual. So really taking a look at how to segregate that, identify trends, root causes, and then how do we fix them and prevent them in the future. Analyze, um, and I always say analyze what you have, act quickly, um, automate workflows, create template denial letters, everything that you can, share, ask, reach out to friends, but then really celebrate the success and build team confidence. A lot of billing staff are not really their work. They're not really great with denial management or understanding denial. So when they have a win, it's important to celebrate them, and create a team environment for them to pass on what they've learned and know. Data analytics and benchmarking. As you pull this all together and you're walking through, you'll find that you're monitoring and improving revenue through a more sustainable workflow. But really, you're going to want to proactively leverage that with some data to support your claims. So, really look at what you can start to track based on what you're measuring as your weaknesses, and measure the improvement in data analytics. Really choosing the right key performance indicators. There's a huge focus for days in AR. There should be a larger focus on net patient receipt. So, how many of the billed dollar, how much did we get back? And also subsequent receipts. Like if you have a lot over AR, maybe identifying current versus subsequent receipts to identify the effectiveness of your denial management strategy. But really choosing the right key performance indicators and bringing a comprehensive KPI dashboard into the organization. It will evolve. Don't go crazy. Start with things that you can measure. But once you do that, it will really drive and show the revenue cycle improvement throughout the organization. Creating optimal workflows, patient satisfaction, and quality care. It can be achieved, and it just is focused on actionable goals. Here's a recommendation after you're all done and you pull everything together. What can you get done in 30 days? What can you get done in 60 days? And here's just a sample of what one organization pulled up for an action plan. And really, how are they, you know, incorporating whatever their weaknesses are and how they align those with benchmarks, goals, and deadlines. And it really is very helpful for staff to take a look and share it with the end users as well. Key performance indicators and best practice are always where you want to be. I just want to tell everyone multiple assessments that I've been on have really led me to one conclusion. There's a lot of focus on days in AR and not enough internal control. So, what happens is it leads maybe patient accounting departments into incorrect priorities, and it can place your organization at risk for compliance audit and recovery. And so, really getting that true denial picture is very important. And making sure that you can do initial and final, but you need to be knowing everything that comes into your organization that's denied and how to fix it. Um, and while, data analytics are an extremely useful tool, we sometimes, as rural organizations, have to create a baseline that is creating an attainable metric, not just something that is best practice. So defining a baseline, define your baseline and your parameters, and then set, measurable but reasonable and attainable goals to celebrate success for your revenue cycle teams. But always expectations should be goal driven. Benchmarks should be analyzed, but everything should be explained with the why behind it to your teams. These aren't blame games. These are not to say you're not effective or as good as Susie next to you. These are just to determine how we are evolving our organization and standing up revenue cycle for success. Um, Again, too much pressure on the revenue management leaders can lead to erroneous claim submissions, and increase in write offs, and lack of appropriate remedy actions that could, in fact, get you more money. So, really, I recommend a one on one with your patient accounting manager, your patient access manager, your HIM, if they're all the same. But someone should have a one on one with them, basically asking what their narratives are, what they're seeing every month if you're not already. So with that, I know we had a small audience today, but I just wanted to see if anyone had any questions, or if there was anything specific that was brought up in the presentation that you'd like to go over in greater detail. If not, you are more than welcome to always have um, the email and reach out, or phone a friend, give us a call. We're happy to help. Like I said, the passion and the intent is really sustaining that rural healthcare environment and building it up stronger and smarter. And with that, I'll turn over to Laura to see if there are any questions or anything came in the chat while I was presenting, and we'll go from there.
Thank you, Carrie. I did not see anything come in the chat, but that was a lot of really great information. I know, actually, we've reached out to you actually in the past. I know as folks leave these webinars, something will come up in real life, in their everyday life, and then have a question about it. And it's great that we have friends to call on to help us walk through those scenarios. So let me check one
Right.
more time. I don't see anything in the chat, but if anyone, if you leave here and you have a question, let me know. If you're watching this on YouTube and have a question, please let me know. And thank you, Carrie, for your time. And we will
Thank
see
you,
everyone
Laura.
next month for our next session.